Hi everyone. It was nice to briefly meet some of you yesterday. I realized that time was short, and to be honest, I also really wanted to find out more about all your work and efforts and could have discussed them for much longer. As we all really want to get down to business, I thought I'd record this presentation. Think of it as a primer to help further thoughts and discussions. That way, next time we can talk about the work and your projects and how we can make them even better and more effective. For those who weren't present yesterday, I'm Asim. I'm an academic GP trainee and a human from the planet Earth. My motivations for being here are to try to make things better for us and the people we see on a daily basis. I've not long left the hospital, and having worked at MRI for 4 years through my academic foundation program and then ACF, I haven't yet forgotten what it's like to work in pressured acute settings with seemingly endless conveyor belt of patients, not people, and with numerous tick box exercises, performers, and checklists. I'm looking forward to spending some time with all of you to better understand your workplaces, perspectives, and problems. I've already heard a little about the pressures on PCIs, diagnostics, and even staff across the region. You're clearly all working really hard to meet the need while also trying to improve services locally and innovate for the future. I've always been into tech and thought I'd go into developing it. I almost joined Dr. Morris in F1 to do some work on his AF tech. However, working with the NHS, I quickly realised that the tech just does what it's told to do. It's by far the easiest part of the problem. The real issue is people and everything around the tech. I've since spent the last few years understanding systems, behavior, psychology, and implementation, how to really influence and implement change within the extremely complex environments we work in, as well as continued my self-exploration of tech. I could spend hours talking to you about QI and how to maximize the return on your efforts. However, today I thought I'd spend a few minutes setting the scene within GM and some of the underlying issues and problems relating to CVD before then going on to discuss a little about what we can all do. I seem to be drawn to problems, and as far as I can understand, CVD is currently one of the biggest threats to society's well-being. So, I'm sure you will all know that CVD is globally the leading cause of death. The latest Global Burden of Disease report published in Lancet last year revealed that hypertension is now the single biggest global risk factor for preventable deaths and disability-adjusted life years. It surpassed malnutrition and infectious diseases even. This diagram shows the cause of death of everyone in Manchester in 2019 and clearly demonstrates the scale of the problem. Hypertension accounts for roughly half of all strokes and MIs, and we currently still don't know 40% of the estimated population prevalence, and of those we know, about only 60% of them are treated to target. We have known about hypertension for ages, yet we are still in the place we are today. At this stage, this is unfortunately not just a primary care or secondary care problem, but a whole system issue, as signified by premature death rates rising for CVD for the first time in 50 years. Since 2014/15, hospital admissions for all ages for CHD have generally been falling, following the national trend. However, GM saw an increase in CHD admissions in 2017/18. Moreover, across the 6 years shown here, CHD admissions have been consistently significantly higher than the England rate. This is likely due to many reasons, which I'll touch on later, and shouldn't just be interpreted as solely due to performance or quality of the healthcare system alone. And note, this is pre-COVID. Over the last 2 years, the pandemic's devastating effect on the UK's health has resulted in the greatest reduction in life expectancy since 1981 or World War II, depending on your source. This graph shows life expectancy at birth for Manchester residents, and you can see this drop here is quite significant. COVID has not only highlighted but exacerbated long-standing socioeconomic inequalities in the UK. Indeed, map of child mortality from 1851 bears striking similarities to a map of COVID-19 mortality rates. It's also basically the same as a map of prevalence or incidence of deaths from circulatory and heart diseases, all essentially following socio-demographic gradients. Despite us knowing about this issue for ages, the relative difference between the richest and poorest in society has been increasing, even before COVID, and has worsened significantly since. Since 2011, improvements in mortality rates for men and women have stalled, both on average and in the most and least deprived areas. Mortality rates, however, show stark differences by deprivation. In 2019, deaths in the most deprived 10% of local areas were about 1.76 times higher per 100,000 for men than in the least deprived 10% of local areas. Socioeconomic inequalities in mortality rates widened further in 2020. Men in the most deprived 10% of local areas were 2 times more likely to die over this period than those in the least deprived 10% of areas. While improvements in life expectancy have been stalling for some time, COVID-19 has resulted in substantial increases in morbidity and mortality. And while we all might be in it together, it hasn't been an even playing field, with the lower socioeconomic class significantly disproportionately affected. UK has amongst the worst excess deaths during the COVID-19 pandemic in Europe, leading to some calling this a syndemic, a simultaneous pandemic of the virus exacerbated by another pandemic of ill health and long-term conditions with aging populations and multimorbidity. The differences in life expectancy between the poorest and richest is now a massive 18 years of healthy life. If you sit on the tram in central Manchester and head outwards, the life expectancy will drop on average by 1 year for every 3 minutes. Some of you must be wondering why I've segued into inequalities and the relevance to cardiovascular disease. Remember that CVD is the biggest cause of preventable deaths, with significant increases in excess deaths over the pandemic in Greater Manchester. This means that inequalities, or inequity, in how we deliver and provision healthcare are critical to the issue, as we are failing to resolve the issues of the people with the most healthcare needs. If we want things to change, we need to change, making it central to the issue and imperative when thinking about how we improve the system, especially in the current climate with massive pressures, workforce shortages, limited resources, massively spiraling costs, and exponential rise in prevalence of ever complex multimorbidity. Some of you may have been taught and still understandably operate on the biomedical model of disease. However, in recent times, we're starting to understand the complex interplay between health or illness and a person's psychology, sociology, and biology, termed the biopsychosocial model of illness. At least when working in primary care and confronted with ambiguous early and undifferentiated illness, the play of social and demographic factors are much more evident. My medical textbook is now almost completely useless when working on the estate in Wythenshawe, which happens to be the largest council estate in Europe. Indeed, health is so much more than physiology or biology, and your genes only partly explain why you're unwell. The starting points for the majority of illness we now see is a lack of health literacy and harmful behaviors or lifestyle factors. This is clearly obvious if you go and stand outside MRI or Wythenshawe, or I expect any A&E for 5 minutes. Next time you're down in A&E, take a look at the waiting room. We're fantastic at treating the biology, but failures to meet people's psychological and social needs are now impacting on the usefulness of these treatments and ultimately failing to actually improve the quality of people's lives. People in the most deprived decile of society are significantly more likely to smoke, be physically inactive, and be obese, and in turn more likely to have lower levels of education. These factors mean that those living in deprivation are significantly more likely to have multiple long-term conditions and be in poorer health. This is why atherosclerosis per se isn't even the root cause of the problem, and why in reality the people you'll be stenting, in the NHS at least, will be more likely to be poor, overweight, smoke, less educated, physically inactive, and of minority ethnic backgrounds. Due to lockdown and the economic instability, almost all of the behavioural risk factors have worsened during COVID. This is a map of Greater Manchester demonstrating the areas with the greatest deprivation highlighted in blue. The Manchester local authority is the second most deprived in England after Blackpool. You see, healthcare doesn't exist in a vacuum, and there is often a complex interplay between healthcare, society, politics, and economics. I personally suspect that our communities and society and level of deprivation in Greater Manchester is probably a large driver of our high rates of CVD as compared to the England average, as opposed to any specific deficiencies in the healthcare system. Although, on the other hand, you could argue it's still reflective of our lack of responsiveness and ultimately a failure to meet the actual or underlying needs of the people we see. Ultimately, the difference in health between the poorest and richest is all essentially driven by CVD. People in the highest deprivation centile are 4 times more likely to die prematurely from CVD than those in the lowest centile. And out of the top 3 causes of death of CVD, cancer, and dementia, this is something we can actually do something about, and right now. This is a complex topic, and I'd love to hear what you guys think and your thoughts on this. So the light bulb moment of COVID-19 experience to date is that inequalities or inequities in health and their causes run deep through our society and through how people access, experience, and receive care from the NHS. To that end, NHS England have launched a new Core 20+5 approach. I think it's surprisingly nuanced, taking some of the complexities into account, but the real world support and top level drive will be needed and is yet to be seen. The 3 core components are the Core 20, a focus on the 20% of the population in the lowest deprivation quintile, which is meant to pick up and take on the overarching impact of deprivation on access, experience, and outcomes. The Plus is an additional focus on local inequalities, determined by the ICS perhaps, in an additional or intersecting population group, for example, inclusion health groups. And the 5 are the 5 key clinical areas prioritized in the NHS long-term plan, and the areas in which we're performing the worst and people have the highest risks. So I'm sure we've all at some point felt like the ones at the top and the ones at the bottom. We are all part of a really complex interacting system, and ultimately the us and them mentality is harmful and prevents us from working together and breaking the historical professional boundaries, leading to frustration rather than understanding. The real benefit of a cohesive system results in something greater than the sum of its parts. With huge financial pressures across the system, we need to start working together if we want to do more with less, as is now necessary. Achieving the ambitions requires a whole system effort. In the past, primary care has been thought of as responsible for identifying risk factors for CVD. Although it does have a vital role to play, primary care is massively overstretched. All the funding in the last 30 years has gone to the hospital. There's been a 500% increase in the number of hospital consultants over the past 5 years, while GP numbers have remained static or declined depending on your data source. There are ultimately many ways of finding the people most at risk so that they can get the help they need. And moreover, we need to start capitalizing on the opportunities we do have. Yeah, as I said, we work in an extremely complicated and ever-changing system. It's no wonder people keep coming to A&E, as despite there being almost every service available, navigating your way through it is complex. The number of people not registered to a practice has been increasing recently, reflective of our failure to convince people that we know what's best for them. These people are, however, coming into hospital or even hospitals. I met a gentleman in MRI who'd been investigated for abdominal pain for 9 years without having been registered to a GP. He didn't even know why it could have been beneficial to him and was frustrated by being investigated 9 times in 4 hospitals in Manchester while being told different things by different people for the same issue again and again. We need to all work together as part of a single system in order to realize the change we are all striving for. Take a step back and attempt to understand what led to a positive thing or even what led to a negative outcome. But remember, the same factor one day may save a life and another day may cause an error. It's not about reducing errors, but maximizing the right outcome most of the time. Don't blame people, as ultimately we're all striving for happiness while avoiding suffering. It's the system's function to facilitate the process of care, of which individuals are but one ingredient. We made the system, and as system leaders, it is up to you to facilitate and direct that positive change. With each 2 millimoles of mercury drop in BP associated with a 7% reduced risk of death from coronary heart disease, 10% reduced risk of death from stroke, we need to make sure that we get the most out of each encounter with a person. As the next time you see them, maybe when their stent has reached the nose, or they present with a stroke, or they now need a cabbage, we will be to get us started. Two general ideas are getting the most use out of the information we already have, while helping to share that information across the primary, secondary, social, community care divide, and starting to get serious about behavior change at every opportunity. Being admitted is a critical time in most people's lives, and the literature shows that people are most likely to commit to and sustain lifestyle and behavioral changes following admission to hospital or other significant life events. There's been a lot of research on human behavior and how to influence people and change behavior. It's more recently spawned into a whole field in its own right, termed behavioral science, and it's received a reasonable amount of attention during the pandemic. I think it was the behavioral scientists that were responsible for all the three-word slogans, for example. Although people are complex, and behavioral science is still a bit simplistic if you ask me, there are some rules of thumb. Common sense doesn't exist, and people often don't make rational decisions and don't tell people what to do. It doesn't work and often has the opposite effect. Use positive language instead of negative. What patients really want is often not to have better blood pressure or lower cholesterol or care about what medicines they're on. What they usually want is to feel better, not die before their time, and be able to do what they need to do to fulfill their obligations and pursue their dreams. We will have far more success if we fit our advice within people's autonomy. The trick is to make people think it's their choice, i.e., perceived voluntariness. Of course, this is on an individual level, but what about on a systems level? Some of you may have come across brief and very brief interventions. They're an evidence-based approach aimed at modifying behavior. Takes only 30 seconds to a few minutes and has a decent amount of evidence to benefit its use. I'm not suggesting we all take a degree in psychology and start counseling every patient we see. However, a quick screening for everyone on every encounter by every person in the healthcare system can start to make that difference. We need that single voice across the system, regardless of if it's dentist, GP, or hospital. Think about the abstract system and its components and ingredients and what you have to play with. The HCAs, for example, on the ward spend significantly more time with patients than the doctors do, washing them, gossiping with them, and even, dare I say it, taking them out for smokes. During the BPM at Home Trailblazer, I've upskilled receptionists and secretaries in how to talk to patients about their lifestyle and BP. Forget proactive care and taking healthcare to people. We're still missing out on a lot of opportunities that are in our hands. We need to start making every contact count. The brief intervention, combined with the ability to refer directly to health programs, could have a huge impact and cost minimal in terms of training, education, and systems. It starts to break those false boundaries to address the underlying issues that brought the patient in the hospital to begin with. I know Withenshaw has an inpatient smoking team. It's beyond belief that MRI still doesn't have any inpatient alcohol team, considering the local population need. Nonetheless, perhaps being able to refer directly to these services for those people who are on the fence could make that difference. NHS Islington, I think, CCG, developed a sequin to normalise and embed evidence-based cessation in hospital. And, for example, motivated patients accepting a referral to quit support quadrupled within the first 6 months of this introduction of the sequin. 50% of our work needs to be focused on prevention as per CPIP. In terms of cardiology, I think that would most likely be getting on top of secondary prevention, and work out in the community more likely also to include elements of primary prevention and opportunistic screening. If you're in the home of someone with heart failure, their relatives are also likely to share some of those risk factors. Think about systems and flows. Take a step back and start asking questions. You'll soon find that there are probably lots of little tweaks that could make a difference. With very little money around, the main focus of this is likely to be better connecting the dots and facilitating the seamless transfer of information while engaging people on their terms. For example, all the BP readings in the hospital. Could the juniors convey that information in a discharge letter? With OBS done 4 times a day or more, just sending that info on in some guise, if nothing else, could help. When I was last in MRI, people would do blood tests every day and sometimes 2 or 3 times a day. What about cholesterol and a HbA1c on the last bloods if one hasn't been done recently? I realize that this is still extra work, but ultimately the work needs to be done, and we need to think about who does the work, when, and how, as that's what's in our control. Primary care is massively struggling and is undergoing forced huge changes. We are supporting them to switch to stratifying high-risk patients and proactive reviews, but even getting a blood test from a person is a 5-step process in GP, and the people with the worst health are also the hardest practices to engage with. We are working really hard to influence primary care, public health, community services, and various parts of the healthcare system in order to work together to tackle this. This is ultimately all of our problems, and we need to figure out how we can make things better across the whole system. Put pressure on the hospital, as it's the one place in society you can guarantee people with the worst health will be. I realize that a lot of services, or all the services, are essentially in firefighting mode, and prevention seems something distant. However, there is a lot to be gained by connecting the dots, breaking the silos, and starting to work together. It is our only option. We can't keep doing things in the same way and yet expect things to change at the same time. Considering the pressures across every area, it's only together can we leverage the resources required to lead to the tangible, essentially transformational change we're all looking for. Thanks for listening. I hope it's been useful and given some food for thought, and I look forward to hearing your thoughts and chatting through things with you all in the future.